able to hear me as well? Clear?
Yeah, all clear.
Okay.
Okay, so it's all yours. So I'm leaving actually. Yeah, so just want to open up for you. Okay, so you can share the screen. I can check and tell you if things are visible or not. Yeah, before I left.
Sure. So we'll just do that.
Sure.
Is it visible?
It's visible now. Visible and clear. Okay.
Hello, is the screen visible?
Yes, the screen is clear and visible.
Okay, so you're all able to see it.
Yeah.
Right?
Yeah, everything clear. Okay.
Okay.
Okay, thank you so much, everyone. And everyone is requested, if it's possible, if you can mute your microphone, would be kind enough. Yeah. So when you're attending, please mute your microphone. Actually, thank you so much, everyone. Okay, thank you, Doctor. Okay, so Dr. Iftasham, you can continue. Thank you. Okay, bye bye.
Yes. Thank you. Bye bye. So hello, everyone. Starting off with, again, cardiology. I hope you all are doing good. So today I would like to go a bit more faster because I did request Dr. Ahmed to give me another class for cardiology because the first day we did only 3 and cardiology is a big part in medicine. So hopefully I would try to cover a bit more on cardiology. I cannot cover all, but yes, covering at least 50 to 60% of the main cases, meaning giving more focus to the questions that keep coming in the exam. So before we start with the first role play, who wants to participate? So who's participating in the first role play? Whoever is willing, I'm happy. Please unmute your microphone and we are ready to start. Anyone interested?
Hello.
Yes, hello.
Hello, ma'am. Can you hear the background noise? Because there is some puja going on in my neighborhood. I think you'll get disturbed.
Okay, no problem. I think if everyone doesn't have a problem because your voice is more clear than the background noise.
Okay. Then I'm ready for the role play, ma'am.
Okay. So I'm sorry, I still couldn't see your name. However,
Ajita.
Sorry?
Ajita.
Ajita. Yes, I've heard your name, and I think we did a role play last time as well, wasn't it?
Yes, ma'am.
Yes. So all the best. Starting off with the first role play, as always, 2 minutes and then 7 minutes.
Sure, ma'am.
So just getting the timer ready for you. So giving you 2 minutes. Are you able to see the screen?
Yes, ma'am.
Okay. So 2 minutes. It goes start. If you have read the question, I have another page for you.
Okay, ma'am. I'm done with this. can I start, ma'am?
No, some more 10 seconds.
Okay.
So there you go. Your 2 minutes up.
Okay.
7 minutes start.
Hello, examiner. I'm Dr. Ajita Pandey, and here's my ID.
So do you understand your tasks?
Yes, examiner.
Do you have any questions?
No questions.
So here's Smith, your patient. You can start.
Okay. Hello, Smith. I'm Dr. Ajita Pandey, one of the hospital medical officer in this hospital. I have come to know from the notes that you have some sort of racing heart, and we have done an ECG. Now I'd like to explain this ECG to my examiner first.
Right.
This is a 12-lead ECG showing the electrical activity of Smith's heart, and there is the PPM looks normal, and the rate is irregularly irregular, and this looks okay. So coming back to the Smith, I'd like to ask few. I'd like to ask few questions to my examiner. Is the pulse? What is the pulse rate of this patient?
We don't have any values.
Okay, so no values. Mr. Smith, from the ECG, I have come to know that you have a condition called atrial fibrillation.
Okay.
So this is a condition in which your heart has abnormal rhythm. Your heart is not being able to coordinate with the electrical activity generated by SA node. SA node is anatomical structure present in your heart, which is responsible to produce regular heart rhythm. Do you get me, Smith?
Yeah, I think it's still not very clear. If you could please make me a bit more clear what's happening.
Okay, this is a heart, and there is a structure called sinoatrial node in your right atrium.
Now, what's that, doctor?
This is one of the chamber you can see in the diagram.
Yes.
You have chambers, and you have a structure called sinoatrial node, which is responsible to generate electrical activity in your heart to conduct this rhythm of your heart regularly. But there is a problem which is responsible for irregular heart rhythm.
Okay.
Do you get this?
Okay. So there's a problem in the SA node, as you're saying.
And SA node, and let me continue. There is a the electrical activity generated by SA node goes through the AV node, okay? And here is your AV node, and there might be some problem in this area, which is responsible for abnormal heart rate and rhythm of your heart. And I want to ask, do you have any other condition like thyroid issues or blood pressure, increased blood pressure, or any other?
No, doctor, I don't have anything happening to me.
Okay. And can you tell me what is your age?
Yep, so I'm about 62.
62. And do you have any other heart conditions?
No, not that I know of.
Any diabetes?
No, no diabetes.
Okay.
Why, doctor? serious problem?
No, actually, when a person has a condition called atrial fibrillation, we usually prescribe some kind of blood thinner so that a person doesn't get its complication like stroke or any kind of thrombosis. But since you do not have any kind of risk factor, I think you will be put in regular follow-up. But before that, I'd like you to visit a cardiologist for further test. We will be doing since we have already done an ECG, we'll be doing 24-hour Holter monitoring and a stress test and some echocardiography to see any kind of anatomical abnormality in your heart.
So what's echocardiography?
It is basically ultrasonography of your heart.
Right. And it's just an ultrasound. What kind of echocardiography would like to do?
I didn't get your question, Smith.
So it's like, are there any types of echocardiography? It's just one that you would do for me.
Okay, there are like 2D or 3D ecography, and that will be decided by your cardiologist. Okay, Smith?
Okay, sure, not a problem.
And also, I'd like to do some full blood examination, thyroid function test, and some electrolyte test to see if there is any problem, any reason behind your condition. I think that's
sounds pretty scary. So now I need to go to the cardiologist, is it?
Yeah, right.
Oh, okay.
So do you have any questions?
No, I think pretty clear.
You don't have to worry, Smith, since you do not have other risk factors.
Yep. So your time's up. I will stop you. But yeah, was there anything more you wanted to add?
Nothing, ma'am.
Okay.
I totally get this.
Yes, that's why I stopped you, because I did get to know that you don't have much more to add because you are almost towards the end. Okay.
Yes.
So first of all, well done, Ajita. Thank you for participating. Okay. So it's not easy like to do a role play. Okay. It's not at all. So I appreciate your efforts in participating. Okay. Coming back to the case, I'm glad you diagnosed this as AF. Okay. So this is a ECG of AF. Okay. Now, in this case, if you all look into the task, we have 4 important tasks. The first one is you read the ECG to the examiner. The second one is you explain or you read the ECG to the patient. Number 3, what investigations you'd like to do. Number 4, what are the complications. It writes very clearly, no history and management. Because it says very clearly no history and management, you are never supposed to ask anything from history. Let it be thyroid, let it be past medical, let it be hypertension, let it be anything, nothing more. You only know he's coming up with palpitations. We don't even ask, can you please tap it on a table for me, how your palpitations are. Okay. So because it says no history and management, it means we do not touch it at all. That's the first thing. So this is a very small and it is a very simple case. It is one of my recalls that I had got in the exam, and this is nowhere in Karen notes. So this was something very new, and it was the first time I had seen this case was during my exam. Okay. So the task was, the first task is read the ECG to the examiner. So if you all remember our format of ECG, the way we always read is, this is a 12-lead ECG with electrical activity. The rate is this much. The rhythm is this. Then we talk about P wave. We talk about P followed by QRS, PR interval, about the ST elevation or depression, whatever. Talking about ST changes, and we talk about the T wave. So let it be any ECG if you remember these points. So today I'm showing off the presentation. There is a reason that I'll be going through the presentation. For all of you, it's getting a bit difficult for me to send screenshots because it goes like up, down, up, down. So that becomes a bit difficult for me. So I would really, really appreciate if you all make your own notes. And I'll be also going through the slides today so that none of you have any issues with the slides or anything. So please make your own notes and I'll be moving the slides as I proceed today so that you all are very aware that what presentation I'm getting rather than asking for a screenshot later because it's giving me a bit of trouble and it's messing up. So I have sent a few, but then I could see that it wasn't in order. So like for every case, it becomes a bit difficult. So if you could please make a note, that'll be really appreciated. Okay, so moving on, in any ECG, we talk about these points. So this is an ECG of atrial fibrillation. So this is just a nice question. It's just a good to know question that I'm throwing. That is, so there is no confusion in the ECG of it being atrial fibrillation. If you all look into the last lead, which is the lead 2, we can see the rhythm is irregularly irregular. So it is the rhythm that is irregularly regular. For the heart rate, in AMC part 2, so it's not the general heart rate that how we calculate. In a case of regular rhythm ECG, which is by 300 divided by number of large squares, we cannot do this one in a case of irregularly irregular rhythm. So it's just a good to know question. Anyone knowing the formula to calculate heart rate in atrial fibrillation? So please type in, or you can, the best is to type it in the chat box. If anyone remembers, especially those who have recently graduated, you can please put it on. So there is a formula on how we calculate the heart rate if there is an irregularly irregular rhythm. The one we know for any irregular rhythm like MI, like pericarditis, it was a regular rhythm, the heart rate is 300 divided by number of large squares. So it's just a good to know question, just to refresh everyone's memory, nothing more. And even to refresh mine, to be honest. So 30 large scale divided by total R. Okay, so you have to have the 30 peaks of QRS and then divide by total, or 30 big squares and then divide by the total R. Now, this is something, so because it is a bit complicated theory, it requires time. In AMC clinical, no one wants to know the exact rate. So the way we say is, this is a 12-lead ECG showing electrical activity. I cannot assess the exact rate. Why? Because you have to sit and calculate. We don't have time for that. So there is no place in the exam that you would sit and start doing additions or subtractions or multiplying. Okay. So it's all a very quick process. Like even if it's a regular rhythm, if it's 1 square, 300 divided by 1, 300. If it's 2 square, 300, 150. If it's 3 square, 300, 150, 100. That's how memorize it so that you don't have to sit in the exam and say, write 300 divided by 2, how much? 150. So keep it memorized. 300, 150, 100, 75, 60, 50. Keep going ahead. So you just count the number of large squares and you say, for 1 square it's 300, 2 squares 150, third square 100, fourth square 75, fifth square 60. Good. So this is how you calculate in a regular rhythm. Coming on to the irregularly irregular rhythm, this is a 12-lead ECG. I cannot, showing electrical activity, I cannot access the exact rate, but the rhythm seems to be irregularly irregular. In a case of atrial fibrillation, we never get any P waves. So there is absent P waves. P waves are replaced by fibrillatory waves, followed by, I'll try zooming in for few fibrillatory waves. Have a look towards the, just the ones towards the end. Can you see many small waves? That's what we call fibrillatory waves. So they don't have a P wave. That's number 1. So no P wave. P waves replaced by fibrillatory wave in any ECG of atrial fibrillation. So because there is no P wave, there is no question of PR, no question of P followed by QRS. However, let's comment on the QRS. The QRS seems to be normal. There is no ST elevation. There is no T inversion. This is an ECG of atrial fibrillation. So how you read it to the examiner is, this is a 12-lead ECG showing electrical activity. I cannot assess the exact rate. However, the rhythm is irregularly irregular. I cannot see any P wave. P wave seems to be replaced by multiple fibrillatory waves. So no PR and no P followed by QRS. However, the QRS complex seems normal with no ST elevation depression or no T wave inversion. This is an ECG of atrial fibrillation. Is whenever you read any ECG to the examiner. That's the first task. Moving on to the second task, explaining the ECG to the patient. Whenever you want to explain an ECG to the patient, please remember, because it's been a very, very important thing in our exam. It's not only with atrial fibrillation. You can also get an ECG of MI and it says explain ECG to the MI to the patient. So when it's explained to the patient, please remember we are never going to sit and explain this graph. That look, this is your ECG. This is the rate. Look how irregular it is between the peaks. That means the rhythm's irregular. So we never talk about the ECG. Then what does this task mean when it says explain the ECG to the patient? It usually means that you explain to the patient what they are having. So you say that the ECG is a representative of the electrical conduction of your heart. And what we found is there is an abnormal electrical conduction of your heart, which is disturbing the normal rhythm. So the rhythm is changing from regular rhythm to irregular rhythm. That's it. That's it. So you basically explain what is atrial fibrillation. You do not need to explain, like as I did the role play. Dr. Ajita, you were mentioning a bit, like, you know, when you started talking about the abnormal conduction, from there you went, first of all, atrial fibrillation itself is a diagnosis to explain. From there, another medical jargon was SA node. From there, another medical jargon was the AV node. And so everything started getting very, 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 very confused. Then you started talking about chambers and hearts. And so there were more of medical terms and it seemed more complicated. So we always like to keep things very, very simple and very, very short. So the explanation is that your ECG represents the electrical activity, which we could see that it is abnormal from the normal rhythm of your heart, meaning your heart is pumping at different times and there is abnormal conduction of your heart. That's it. Now, this is what we call atrial fibrillation. It is a medical diagnosis and these were the findings which we found in your ECG. Okay, now that's it. That's it to the patient. Next task. What investigations you would like to do. So this is a very, very specific case where they want to hear about the specific things. Okay, what investigations you would like to do? Okay, if you're looking for the cause, we know there are many causes of atrial fibrillation, a whole list. Let's have the most common ones: ischemic heart disease, valvular heart disease, especially mitral valve. It can be because of hypertension. It can be because of thyrotoxicosis. It can be because of lung conditions. It can be because of no conditions. However, no causes, sorry. So the top four being ischemic heart disease, mitral or valvular heart disease with hypertension and thyrotoxicosis. Over here, if you would like to do some investigation for the causes, like I would like to do a thyroid function test, that's completely acceptable. But the more important is, rather than finding the cause, it is now this patient has been diagnosed with atrial fibrillation. What would we like to do? So our investigation of choice is echocardiography. The type of echocardiography, so yes, it is the ultrasound of the heart. The usual one that we always do is the transthoracic echocardiography. But in atrial fibrillation, the type of echocardiography that we do is called, I'd like someone to participate. So what is the type, the specific type of atrial, the echocardiography that we do in atrial fibrillation? Anyone knowing? Anyone would like to type? TE. What's a TE? Transthoracic echocardiography, is that what it means?
Transesophageal.
So the other one is very good. It's called TOE, transesophageal echocardiography is the echocardiography choice in case of atrial fibrillation. Good? Okay. So transesophageal echocardiography followed by the other investigation you can do is thyroid function test. If you want to do, because these patients we start on warfarin, if required, you are always welcome to do an INR if requiring warfarin, but your main investigation remains a transesophageal echocardiography with thyroid function test, with coagulation profile, with INR if given warfarin. That's it. Okay, let's move on to the last task. What are the complications? So this needs management, because if not treated, you are at an increased risk of having two important complications. So the two important complication, number one, thromboembolism. So we need to explain what is thromboembolism. There is a high chance that the blood can clot and can block the blood supply. If in your brain, it'll cause a stroke. If in your heart, a heart attack. If anywhere, it'll cause ischemia or lack of oxygen to that tissue, leading it to be more or less viable. So this is the one complication. The other complication is cardiac arrest. The heart can stop pumping at any time. So these are the main two complications that a AF patient can develop. This was the whole case, nothing more, nothing less. So reading the ECG to the examiner is, this is a 12-lead ECG showing electrical activity. I cannot assess the exact rate. However, the rhythm seems irregularly irregular. There is no P wave because P is replaced by multiple fibrillatory waves. Sorry, where did my presentation go? Okay, not a problem. Sorry, just trying to put it in again. Right, so sorry, again starting. This is a 12-lead ECG showing electrical activity. Cannot assess the exact rate. However, the rhythm seems irregularly irregular. Cannot see any P waves because P is replaced by multiple fibrillatory waves. So no PR, no P followed by QRS. However, the QRS complex seems to be normal with no ST elevation depression, with no T inversion. This is an ECG of atrial fibrillation. So Smith, we have just done a 12-lead ECG, and this represents that you have a condition called atrial fibrillation. Have you heard of it? It means that there is an abnormal electrical conduction of your heart, which is represented in this ECG by having an irregular rhythm. It means that usually all people, they have a regular rhythm, which in your case, due to unknown causes, is irregular. Okay, so what are the investigations we'd like to do? First of all, yes, we can do some investigations to find out the cause, like thyroid function test, like a chest x-ray if you want to rule out the pulmonary causes, but the main investigations remains a transesophageal echocardiography, which is an ultrasound of your heart, and we can do some coagulation profile. And if we start you on a particular medication, which is the treatment, which is warfarin, then we would need to monitor INR. The complications are, if we do not treat this condition, it is at an increased risk of forming clot, which we call thromboembolism. So if this clot goes to your brain, it will stop the blood supply in the brain and cause a condition called stroke. Similarly, if it blocks the vessels of your heart, it can lead to myocardial infarction, which is heart attack, or it can sometimes block the vessels of any part, causing less blood supply, less nutrition, and that area becoming more less viable. The other complication is the heart is at increased risk of stopping its pumping action, which we call cardiac arrest. Do you have any further questions? I can give you some reading materials. Over here, you can always talk about 4 hours because nothing very emergency, nothing very urgent. We are not admitting. So talk about, I will refer you to a cardiologist to have a better opinion on that. I can give you some reading materials. If you develop further racing hearts or any kind of chest pain, please come back. So this is where you can use your 4 hours. Even if you don't use it, it's a pass. Any questions for this case? So this is a pretty short case today I started with.
Yes, ma'am. What about the chat score in the treatment of atrial fibrillation?
Okay. So what about chat score? So chat score doesn't come here. When do you get chat score? Chat score happens when a patient comes with stroke and in addition has atrial fibrillation. That's when we do chat score. So in general, we won't do in a patient just coming with atrial fibrillation. We don't do chat score.
Okay, thank you, ma'am.
Clear? Any further questions? Everyone clear? Please type in a bit if it's clear so that I can move.
Yes.
Clear? Thank you. Clear? Okay. Moving on to the next case. Who's coming? Anyone who's happy to join? Anyone who's happy, please unmute your microphone and we are ready to start. Please feel free to participate because this is one of the opportunities that you get to participate.
Yes, ma'am, I can do that.
Okay, so am I having Dr. Tashwin?
Yes, ma'am.
Okay. Okay, so your next case, are you ready?
Yes, ma'am.
Okay. Starting off with 2 minutes, are you able to see the screen?
Yes, ma'am.
Okay. Before you all start, and even before you start, just showing you, so the ECG, we have shown you all the points. ECG showing abnormal rhythm of your heart. Investigations are transesophageal echo, warfarin, INR, full blood bleeding, coagulation profile. Complications are cardiac arrest and thromboembolism. Okay, sorry doctor, are you ready?
Yes, ma'am.
Okay, so your next case starts and your 2 minute starts now. You're ready to start?
Yes, ma'am.
Yes, please start.
Hello, doctor. This is my ID.
Mm-hmm. Do you understand your tasks?
Yes.
Do you have any questions?
No.
Okay, so this is your patient. Sam, you're ready to start.
Okay, before I proceed to Sam, I need to know is my patient hemodynamic stable? His blood pressure?
Yes, he's stable.
Okay, thank you. And what about his blood pressure or temperature?
Yes, he's stable. He's stable.
Okay,
He's
thank
stable.
you. Hello, Sam. My name is Dr. Ahmed. I'm one of the junior doctors of this hospital, and I'd like to ask a few questions about your pain. So, are you
Sure.
having chest pain now?
Yeah, doctor, I'm having some chest pain now.
Okay, could you point with one finger where exactly is the pain?
Right in the center of my chest.
Okay. Is it hurting a lot right now? On a scale of 1 to 10, how would you rate your pain?
6, 7?
Okay, so are you comfortable to proceed with the further history, or you want some painkillers?
So some painkillers would really help.
Okay, with the permission of my, with the consent of a patient, I would like to prescribe some painkillers.
Thank you, doctor.
Okay, so are you comfortable now?
Yeah, feeling better.
Okay, okay, so for how long have you been having this pain?
So it's been for the last 1 month, but it's been like initially about 2 or 3, but then I feel that it has started getting worse, and now it has reached about 6 or 7.
Okay, so it started gradually. And when did the dizziness start?
The dizziness started, I think, almost the same time.
Okay, so does the pain, does it go anywhere? Does it go at the back of your chest or to the back?
No, it doesn't go to the back.
Does it go to the shoulders?
No.
On your jaw, arms?
No.
So it's located at the center?
Yes.
Okay, are there any aggravating factors that you might have noticed about the pain?
No.
What does the pain increases on when you do some physical activities?
Yes, doctor, it does sometimes.
Okay. So does the pain increase when you lie down?
No.
Does the pain have any relationship with breathing? Like, does the pain increase when you breathe deeply?
Oh, no, it doesn't.
Okay. So, are there any associating factors regarding the pain? That is, do you have fever?
No, I haven't noticed any
Recently,
fever.
did you suffer from flu recently?
No.
Okay, if you don't mind me asking, but how do you describe yourself as a person? Do you feel agitated or anxious most of the times?
No.
Okay. And do you smoke? You don't mind
Yes,
asking.
I do.
For how long have you been smoking?
So I've been smoking for the last 35 years.
Okay. Okay, so about your dizziness, did you ever have an episode of losing consciousness and falling down?
No.
So since since when are you experiencing this dizziness? Before or after the pain?
I think both of them came in together. I did feel dizzy for a while. Yeah, and then the chest pain started getting worse, but the dizziness didn't go away as well. It was there.
Okay, and do you have any history of hypertension?
No, I don't.
Yeah, do you have diabetes?
No.
Okay, thank you. I'd like to turn to my examiner and ask him a few questions about you, if you excuse me.
Sure, not a...
Okay. So, I'd like to know if my patient is the general appearance of my patient.
Yep. Anxious?
Okay, he is anxious, and what about, is he anemic? Is there any pallor?
Yeah, we do see mild pallor.
Is he cyanotic?
He's not cyanotic.
Okay, are there any edema?
No edema.
Any signs of dehydration?
No.
Okay, are there any ECG done?
We can do one. We don't have an ECG, but yes, we can certainly do one.
Okay. I need to do a thorough examination of the cardiovascular system.
That's right.
Where is this apex peak? Is the apex peak located at just below the nipple, 9 centimeter from the midline?
Yes, it is.
Are there any palpable P2?
No.
Are there any parasternal heave?
No.
Any thrill?
No.
Any auditory auscultation? Are both heart sounds audible?
Yes.
Are there any murmur or added sound?
No.
Any pericardial rub?
No.
Okay, I would also like to do examination of the respiratory system. Is the chest wall expanding on both sides symmetrically?
Yes.
And the hearts and the breath sounds is vesicular?
Yes.
Symmetrical on both sides of the chest?
Yes, symmetrical hereditary.
Is there any X-ray that is available of his chest?
So X-ray is an investigation. You can always order.
Okay. Thank you. I'll have to turn to my patient now.
Sure.
Okay, Sam, according to the examination and according to the history and examination, and what I think, you have some cause of chest pain which could not be evaluated from the history. For that, I would like to do further investigations, if it is okay with you, of course. And if there is any kind of abnormalities that I find, first I'd like to do an ECG. If there are any kind of abnormality I find in the ECG, I would call the cardiac registrar and he will come review you for further management. Is that okay?
Yep. So what do you think, doctor? What is the reason that I'm getting some chest pain and I feel dizzy? Yep, so your time's up, but still, I would let you go.
Ma'am, I don't think, no idea of the diagnosis now.
Okay, not a problem. Good job. Okay, very good job. Thank you for participating. And it is not an easy case, okay, especially if you do not know, that's when it becomes a bit difficult for this case to go through. However, this is one of the very, very common cases that has even come up this year. So I've just had I was going through the questions when I could see this, and that's why again I made a personal request to Dr. Ahmed to please give me a cardiology class again so that I could do this case. So this was one of the main reasons I had a repeat of cardio. Okay, so this is a case that you see that a 50-year-old man is in your GP clinic, number one, so GP, and complaining of chest pain and dizziness for the last 1 month. Your task is to take a history. We all know of chest pain. The first things should happen at a go. Number one, is my patient hemodynamically stable? I'm very happy that you did ask. Your patient's stable. If someone tells you your patient's stable, it means the vitals are within the range. So that's when it is no longer necessary to ask at that time that what is the pulse, what is the blood pressure, why? Because he is stable. Okay, so that is the first thing. Okay, so hemodynamic stability, because he's having chest pain, we don't know what's the reason. Let's have him in a resuscitation cubicle, and I would like to do an ECG. So these three things should happen first in any case of chest pain. So yes, you did want to have an ECG, but then again, it went a bit up, down, because somewhere in physical examination, you talked about ECG. Somewhere in physical examination, you asked for an X-ray. So ECG is an office test. You can either do it at the beginning. If not, do it in the office test. The chest X-ray is an investigation. You can always order during your management. Okay. So moving on to the hemodynamic stability, resuscitation cubicle, and then going for an ECG. Okay, so I did tell you we don't have an ECG, but yes, certainly we can do one. Okay, meaning I don't have any ECG to show it to you. Coming on to the chest pain, because he's coming on with chest pain, I was very, very glad that you had covered all questions. I have no complaints there. So could you please tell me where exactly is your pain with 1 finger on a scale of 1 to 10, how severe? Would you like to have some painkillers? Please always remember painkillers. Do you have any allergies? Dear examiner, with the patient's consent, I'd like to give some pain relief. For how long is the pain? Is it the first time? Sudden or gradual? Nature of the pain? So that was something a bit missed. Constant, sharp, dull, Okay, anything making your pain better or worse? You weren't specific, so I didn't give you any aggravating factor. You did ask me, was there anything making your pain worse? I said no. Why? Because you didn't ask me specifically. The next question when you asked me, does any activity make it worse? That's when I said yes. Why? Because you did ask me specific questions at that time. Okay, so anything making it worse? Yes, activity. Anything making it better was rest. So if you would have asked me, does rest make it better? Yes. Radiation was very, very clear. Does it go to the back? Does it go to the shoulder, to the arms, to the jaws? No. So there is no radiation. Good. So that was a very good attempt on chest pain. So coming back to, from the history, what do you all get to know? A chest pain that aggravates on activity, relieves on getting rest. What is the diagnosis?
Angina.
So this is a case of angina. But the trick is, apart from chest pain, I also have dizziness. So if you all remember my format, whenever you have two symptoms, please elaborate your symptoms irrespective. So you did see chest pain, we elaborated pain. The next thing that we can see is dizziness. So dizziness needs to be elaborated, meaning I can also see apart from chest pain, you are coming with dizziness. So is it for the same duration? Which one came in first? Chest pain, dizziness. Okay. And is it the first time? Do you feel, so dizziness meaning, do you feel that you are spinning or the environment spinning? Why? We want to see that whether it's vertigo or not. Okay. Then the next question. Did you ever have a fall? Why? Dizziness, syncope, neurological things. Okay, moving on to, because you're having dizziness, the other reasons can cause is also maybe ear or ENT. So any ringing of the ears, any ear pain, any ear discharge, ear infections? No. What is the other thing that can cause dizziness? So I talked about neurological, vertigo, ENT. So vertigo covers both ENT, neurological. What else will cause dizziness?
Postural hypertension.
Postural hypertension. Okay, so are you on multiple medications? No, I'm not. So postural hypertension goes off. Something more? Dizziness is caused by, could you please repeat again? Subdural?
Subdural hematoma because age.
Okay, so subdural hematoma, first of all, would need to have a history of fall or a trauma for that to happen. That's number one. Number two, whenever they are more elderly or alcoholic, that's another thing. But most importantly, rather than dizziness, they would come with headache, very profound headache, confusion. Dizziness is one of the things, but usually they would come even with weakness in one part of the body sometimes. But the more presenting complaint is headache, which worsens on bending forward or on cuffing. So that's more with subdural hematoma. They have a history of fall, and then they come with headache or weakness, or it develops later on. Okay, so for example, I had a fall today, and then maybe after 1 to 2 days I come up with headache, I come up with weakness. Why? Because it has accumulated. So subdural hematoma with dizziness, yes, dizziness is one symptom, but on top we have other big symptoms. So not having subdural hematoma as a DD here. Volume less, okay, bloodless. So what do you call that?
Anemia.
Anemia. So if anyone is having anemia, they would come with weakness, feeling tired, effort intolerance, racing hearts, and dizziness. So if you would have asked about anemia, you would have got something positive. For example, what can cause anemia? So how is your diet, first of all, right? So are you a vegetarian? So no, I'm not a vegetarian. I have a good diet. The other thing that can always cause anemia is bleeding. Let it be external, let it be internal. So, do you have bleeding from anywhere of your body? If you would have asked me, like, I wouldn't be very strict, because I would really appreciate if you would have gone till anemia. So I would have said that yes, I do have bleeding from my back passage. If in the exam you do not get and they tell you that do you have any bleeding anywhere and they tell you no, ask again specifically, do you remember or recall of having any bleeding from your back passage? Okay, why? Because they usually have a history of melena. They have bleeding from back passage. So this is the cause of dizziness. So chest pain explored, dizziness explored, then you're free to ask any further questions on chest pain to rule out DDs. So any short of breath, any racing hearts. You already did ask about the pain going to the jaw, pain going to the shoulder. You asked because you're thinking of MI. You did ask, did I have any fevers, any flu because you thought of pericarditis, about any trauma or short of breath, respiratory, any heartburn, GRD, any rash, musculoskeletal, and yes, you did ask how I am as a person. After you do this, we can do SADMA. So smoking, alcohol, drugs, medication, allergy, past medical, surgical, family history of sudden cardiac deaths. Moving on to the physical examination. So now you have more two systems, meaning chest and GI more important, but then again, our chest pain differential also has abdomen and respiratory, so we'll do three: cardio, respiratory, and GI. So let's start. Dear examiner, I would like to know the general appearance. Moving on to the vitals, they're still same as before. Looking for any signs of pallor, which you did get. I did say mild pallor. Okay. However, others were all negative in terms of pickle, no cyanosis, no lymphadenopathy, edema, dehydration, or edema. Moving on to the cardiovascular. So cardiovascular inspection, no pulsation, no scars, on palpation, apex beat, left fifth intercostal space, 9 cm for midline, normal in character with no palpable P2, no left parasternal heave, and no thrill in any of the four area. On auscultation, heart sounds are dual with no added sounds. On respiratory examination, I'd just like to know the breath sounds vesicular. Are there any crackles or any added sounds? So no. Coming up to the abdomen, starting off with inspection, any distension, on palpation, any tenderness, on percussion, is it tympanic, on auscultation, bowel sounds heard, and with the patient's permission, I would like to check for hernia, like to check for the genitalia, but importantly, coming to the most important point, why? Because this patient has melena, is DRE. So doing a digital rectal examination. Before we do a digital rectal examination, is there any fissure? Why? That's the only condition. If there is a fissure, it's highly contraindicated. So is there a fissure? If not, I'd like to do a DRE. The moment you would have said DRE, I would have said there is blood on the gloved finger. Finishing off with office tests, you're always welcome to do an ECG because you didn't have an ECG, and maybe you can do urine dipsticks or blood sugar, whatever you'd like to do, but ECG would have remained to be an important office test for this case. Moving on to the management. So over here, the management or the diagnosis is most likely what you have from the history and physical examination is what we call angina due to anemia. Have you heard of this? It is because that you're having some bleeding from your back passage. There's decreased blood volume in your body, for which the heart is pumping harder to pump blood to all parts of your body, which is giving you this chest pain, which we call angina. Okay, why is it happening? Decreased blood volume, meaning anemia. What is anemia? You're having less blood in your body compared to the normal. Now, what to do? The next step is we would like you to be admitted in the hospital, and you'll be looked after by two teams. One is the cardiologist, the others are the gastro. So what are the cardiologists going to do? They're going to evaluate further for your chest pain. So they're going to do a chest x-ray and echo. They're going to do the tumor, not tumor markers, the troponin, the cardiac enzymes, to look that you're not having MI. At the same time, what are the gastro people going to do? Because you're having melena, they're going to check for FOBT and if required gastroscopy, colonoscopy to look for the cause of melena. Depending upon the investigations, you would be reviewed. So starting off with the full case again. So first of all, is my patient hemodynamically stable, resuscitation, cubicle, and ECG. Okay, coming on to the pain, all pain questions. So the first pain question is on the center of the chest, point with one finger. For how long? Is it the first time? Would you like to have a painkiller on a scale of 1 to 10? How severe? No allergies. With my patient's permission, I would like to give some pain relief. Tell me more about the pain, sudden or gradual, nature, aggravated by exercise, aggravated by activity, relieved by rest, by medications? Does the pain go to the jaw, to the arm, to the back, or to the shoulders? And apart from the pain, I can also see that you are having dizziness. So could you please tell me more about your dizziness? So is it that you feel you're spinning or the environment spinning? Did you have a fall? Did you have any weakness anywhere? And do you have any ringing of your ears, any ear pain, followed by are you bleeding from anywhere, especially your back passage? Moving on to the other causes of chest pain, any short of breath, any racing hearts, any trauma, any heartburn, any rash. How would you describe yourself as a person? And smoke, drink, drugs, and medications, allergies, past medical condition or surgical I should be aware of, any family history of sudden cardiac deaths. Moving on to the physical examination. Dear examiner, I would like to know the general appearance, assuming the vitals same, looking for pallor, dehydration, cyanosis, lymphadenopathy, edema, whatever you would like to look, and on the cardiovascular, doing a full on inspection, visible pulsation, scars, palpation, apex beat, left fifth intercostal space, 9 cm from midline, normal in character. Then moving on to no palpable P2, any parasternal heave, thrill in any of the 4 areas. Are the heart sounds dual with no added sounds on auscultation? I'd like to do a respiratory system examination. Are the breath sounds vesicular, bilateral air entry with no crackles or creps? Coming on to the abdomen, on inspection, is there any distension, any scars? On palpation, any tenderness in any of the quadrants? Moving on to percussion, is it tympanic? Are the bowel sounds heard? With the patient's permission, I would like to look for the genitalia, the hernia, and a digital rectal examination. First, excluding there is no fissure. If I do a digital rectal examination, do I see blood in my gloved finger? I'd like to finish off with office tests, a urine dipstick, but importantly, an ECG blood sugar. Moving on to the management. So Sam, from the history and physical examination, most likely what you have is a condition called angina due to anemia. So have you heard of that? It means that because you're having some bleeding from your back passage, you're losing quite amount of blood, for which there is decreased blood volume in your body, for which it is affecting your heart, meaning your heart has to pump more harder to transfer or to have adequate blood flow to all parts of your body, for which you're experiencing this chest pain. And because of having a decreased blood volume, you are experiencing dizziness. So I would like you to now be admitted in the hospital, and you'll be seen by a cardiologist who would assess the reason for your chest pain and do investigations like an echocardiography, a chest x-ray. They would do some cardiac enzymes, and the gastroenterologist would come and investigate for the cause of your bleeding from your back passage by doing some investigations like full blood, looking for FOBT, doing a gastroscopy and colonoscopy, and you would be managed depending upon the investigations. Do you have any questions? Please see if the case is clear to all of you. So Dr. Tashfeen, clear?
Yes, ma'am, clear now.
Okay, good. Sure. So Dr. Rumana, you're next. Just before I move on to the next one, just would like to know from everyone, is it clear or not clear? Clear? Okay, so happy for the next one? I see I have 17 participants, but I don't see anyone writing anything to me. So please let me know. Clear. Good, good, good. Okay. So Dr. Rumana, ready for the next case?
Yes, ma'am.
Okay. So giving you 2 minutes and then 7 minutes. Happy on that?
Yeah.
Okay. So the general appearance. Sorry, before I give you the thing. So yes, CVS, abdomen, DRE, angina due to anemia. Would like to admit you. Do investigations, cardiac and gastro. Depending upon the results, you are managed. So Dr. Rumana, here goes your case, and your 2 minutes starts now. Yep, your 7 minute starts.
Hello, doctor. How are you? This is I am a junior medical officer in this hospital, and this is my ID card.
Yep. Do you understand your tasks?
Yeah.
Do you have any question?
No, but my patient is hemodynamically stable now. What is
Yes.
the BP now?
So the blood pressure is 165 by 100 as given.
Okay. So can I proceed?
You're ready to start.
Okay. Hello, how are you? Can I know your name?
Yes, so my name's Paul, doctor.
Oh, hello, Paul. How are you?
Yeah, I'm pretty good, doctor. So I just came in because I got this wound in my hand, and the nurses have just fixed my wound. But
Okay.
I don't know, like, it seems that I have been asked to stay because you're a bit worried.
Okay. So now, incidentally, they find your pressure is right, okay?
Okay, so but I know I have high blood pressure. It's not something that I don't know, that I have been diagnosed with hypertension pretty long back.
Okay. So you are taking your medication properly?
Like I do take, it's been a while I haven't taken my medications.
So you have diagnosed with hypertension how many years ago? 3 years ago, right?
3 years ago, that's right.
So you are regularly taking your prescribed pain dropping, right?
Oh no. I remember taking it for a month or two initially, but then it has become more of irregular. and I can't remember taking my drug for the last 3 to 4 months. It's like because I'm a police, so I'm very busy. So you know that, doctor, that how stressful our job is. So I just don't sometimes remember.
Okay. So you forgot to take medicine, right?
No, I do remember, but then I think okay, and it's just somehow that I have been skipping my medications for a while, I would say.
So you think you are okay, so you don't need medication like this?
Oh no, I don't think I don't need. It's just that like I'm doing pretty well. I'm always very busy. I don't get that time, so it just gets missed.
Oh, okay. So do you have any other disease besides hypertension, like diabetes or any other complication, any other disease?
No. This is the only thing I think I know I'm having.
Do you have asthma or any other?
No.
So, okay. So, do you have any habit of smoking?
I do smoke.
Okay. Any habit of alcohol or any habit of drug, recreational drug?
Oh no. I don't take recreational drugs. I catch people who do that, but however, I do drink sometimes.
Oh, okay. So, do you have any allergy to any type of food or anything?
No allergies.
Okay. So, okay. So, which time you usually took your medicine when you was regularly take your medicine? Which time you usually took the night?
So, yeah, I take one in the morning and I take one at night.
Okay, but also which time you remain busy?
I mean, I work at shifts, so it's like sometimes busy at morning, sometimes during the evening, sometimes during nights.
Okay. So, I want to talk with my examiner. Should you please don't mind?
Yep, sure, not a problem.
So, examiner, do you have any test for this patient? Any office test?
What are you looking for?
Like a urine test, urine lipstick test, or ECG or anything like?
No, we don't have an ECG.
Okay.
Yep, we can always order a urine dipstick.
Okay. So, what is the general general examination finding of this patient?
Very healthy.
Okay. So, I want to move on to my patient for counseling because I think he's the only one problem that is hypertension. Besides this, he have no disease. So, please excuse me.
Sure.
So, Paul, yeah, you know you have hypertension, right?
Mm-hmm.
But you are not taking medication because you told me you are so busy. I could understand you're so busy. But do you know what is the complication of hypertension? Or do you know if you don't take medication, what will be the consequences of this?
Mm-hmm. No, I don't.
If you don't treat hypertension, don't regularly take your medication, your hypertension will not be controlled. In that case, it remain high blood pressure. Okay, so cases of high blood pressure is very bad. It may have very important complication is ischemic stroke. That means it causes damage in your blood vessel in your brain, which causes paralysis, which causes weakness in your body. Or do you know paralysis?
Yeah, I do know.
Yeah. So it's the main complication. Another complication is your in case of raised hypertension, it may affect in your heart.
What is that, doctor?
Like it may causes your heart chamber enlargement of heart chamber, which is called hypertrophy of left heart.
Right.
Okay, so then it causes your structure damage in the structure of your heart. Okay.
Okay. Time up, but continue.
Another one is so it day by day it will increase your mortality, morbidity, and it will be not good for you. So can I make you understand what is the consequences of uncontrolled hypertension if you're not treated properly?
Yeah, I mean, it sounds scary knowing like what you were telling me.
Yeah, you can easily make a note in your notepad, like you have to take medicine that time and that time. Then you can easily take medicine if you become forgot, and you can come to follow up in every month or every 3 months if you want, so that you can know what is your condition like this.
Okay.
So you want to know anything? Anything else?
Oh, no. I think I'm pretty clear.
Okay.
Yeah. Is there anything more I should know?
No, but I am giving you some reading materials of hypertension and hypertensive disease that consequences hypertension. So you can learn more.
Sure. Not a problem. Thank you, doctor.
Thanks for coming.
Okay, thank you.
Done? This first counseling case for me, because I never did any counseling role play.
I couldn't understand. I'm sorry. It's a difficult case. Like especially, it's very hard to understand the task itself. What the task means when you look into the first task, assess the patient's compliance with medications. So the sentence itself is a bit complicated, for which it makes you all puzzled. I'm sorry, but it is a difficult case. But I'm glad you participated and you did really, really well. Okay, so good on that you have been like so the things that we see initially is when someone's new and someone's participating, you keep talking for 8 minutes. Let it be whatever you talk. Okay, sometimes it may make no sense, but you are talking is what we want you to start off with. Okay.
Yeah.
So it was good that you have covered your 8 minutes. I'm glad. Yes, there were a lot of things that you covered, but there are again the framework I would be telling you. Okay.
Yeah. Thank you.
Okay, so good job. Thank you. So moving on to the case. So if you all see the case, first of all, coming to a GP, in caps lock, it's a 30-year-old man. So 30-year-old is something very, 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 very significant when it comes in terms of Australia. Like 30 years is very young age. Okay. So now what happens is he's being diagnosed with hypertension and he's been given Benadryl, but he has not been taking his Benadryl. Blood test shows all other bloods are good, but his blood pressure today is 165 by 100. Now, assess the patient's compliance with medication means your task is to understand why is he not taking his medication? What is the problem there? Okay. So, before I move on to the case, I'll be talking about all the main points and then I'll go to the case. So, why cannot someone take a medicine? For example, consider yourself, consider anyone, let's consider myself, that I have been diagnosed with hypertension and I am not taking my medications. Now, it can be because of mainly 3 broad headings. Number 1, it can be because, let's talk about myself, okay? First of all, about myself is that I don't like taking medication, that I need to take it regularly. Or so this is one problem in me. Okay, or it may be that I just don't know why I have been given this drug. So I don't know what is hypertension. If I don't take this drug regularly, what can happen? I don't know anything. The other thing, what can happen is I have herbal beliefs. So I don't believe in medical treatment. I believe in natural herbal remedies. That's whatever you have given me, I don't take. So these are when the problem is in me. It means my problem. Okay, let's take it to the other category. As I have said, 3 broad categories. Either it is patient problem, or it is the medication problem. For example, perindropil is an AC inhibitor. It can give you a side effect of cough. So for example, medication problems are number one, side effects. It is that I get this cough and that's why I don't take it. Or I develop some other side effects and that's why I don't like this drug. Number two, I don't have money to buy this medication. I don't want to spend money on this thing. Okay? Number three, doctor, you have given me this medication twice, thrice. I don't even remember that I need to take it so many times in a day. So these are the problems with the medication. It's either a problem in the side effect, a problem in the cost, or it's a problem that I like with the frequency. Now, coming on, so two broad headings done. One is patient problem, the other one is medication problem, and the last one is the doctor problem. So doctor problem means that when I have been diagnosed with hypertension, my doctor didn't explain me properly what is hypertension and what are the complications, meaning I do not have proper insight into what can happen if I don't take my medication regularly. Why? Because the doctor didn't say anything. He just said, oh, you're having hypertension, I'm giving you medication, take it regularly. That's all for today. Meaning you had a short consultation, or he didn't explain you, meaning that's why you're not aware what could happen. Or it's because he might have started explaining you, so look, what you have is a condition called hypertension. You have to take this drug regularly, otherwise you'll develop hypertensive retinopathy, hypertensive nephropathy, hypertensive. And that's why I could not understand what he said, because I do not know what is hypertensive retinopathy and nephropathy. Good. So the three broad headings are, it can be the patient problem, it can be the medication problem, or it can be because of the physician problem or the medical problem or the doctor problem. So these three is where you have to sit and assess where is the problem that he's not taking his medication. Okay, so whenever anyone is diagnosed with something, it's a very general way. So as I started, you got to know that I am a policeman. That's something I just told you. And I told you that I have got a wound and I've just got that dressed. Okay, when I said about a wound, a very general question or a courtesy question would be that, oh, what happened? You know, how did you get that wound there? So again, the answer would be that I'm a policeman and I've just been engaged in a fight with a criminal and that's how I got this wound, which makes you feel, okay, it's very normal. And then you can always ask, has it been dressed? Are you okay with the wound? So now, meaning wound part is gone. Apart from that, you see that the blood pressure is high. So let's start talking about that. From the notes, I can also see that you have been diagnosed with hypertension. And I do find your blood pressures elevated today. So could you please tell me, when were you diagnosed with hypertension? Meaning you have to explore on hypertension. Why? Because this is something already diagnosed. It's in the stem. So when were you diagnosed with hypertension? What symptoms did you have at that time? What investigations did the doctor do for you? Who confirmed that this is hypertension? What medication were you given? Were you given perindropil? What was the dose and how many times you had to take it? So, did you take your medication regularly? Did you have regular follow-ups with your doctor? So these are the general questions anyone comes with hypertension you would like to know. Okay, you can always ask about any other comorbidities or any other diabetes, that's always there, but first get an insight of what happened. When was he diagnosed? What investigations? Because 30-year-old with hypertension, everyone's going to look for secondary causes. Okay, so moving on, once we have explored on hypertension, then we move on to the particular questions. Meaning, so could you please tell me that as you have been prescribed with this, you have not been taking it regularly? May I know why? So is it because that you develop side effects? So I'm starting off with medications. Is it because of the side effect? Is it because of the cost? Is it because of the frequency that you forget because you're so busy that you need to take this again and again? Moving on, is it because you do not know what hypertension is, or you have herbal beliefs more than medications? What is hypertension? The moment you were diagnosed, did your doctor explain it to you properly? Were you aware that if you do not take this drug regularly, what are the side effects that can happen? Was it that you had a very short consultation with the doctor the time you were diagnosed? Was it that he had used so much of medical terms that you were unable to understand what he tried to explain you? So we have done patient, we have done medication, we have done doctor. That's when you move on. Every history ends up by doing SADMA, past medical, surgical, family. So that is your first task. Meaning, you first assess when he was diagnosed. First of all, why is he here? And then you assess regarding his hypertension. When was he diagnosed? What symptoms he had? What investigations were done? Who diagnosed it for him? And then what medication, how much, what was the dose, the frequency, and then did he have regular follow-ups or not? Then we move on to whether it's a problem with the patient, whether it's a problem with the medication, like cost or side effects, frequency, or is it a problem with the doctor? You're not aware, it was a short consultation, a lot of medical jargons, you weren't explained the complications. What is the problem? We finish off the history by doing SADMA, past medical, surgical, and then family history. Moving on to the last part. Explain the complications of uncontrolled hypertension. So meaning, again, this is counseling. Okay, so before we talk about the complications of hypertension, these are the two cases that you need to ask the examiner before you explain for one thing. I'll tell you what the thing is. Something that we have was very important in a case of MI. If you didn't do that in a case of MI, you will not pass. What was that thing? Anyone would like to type in or speak up?
Sorry, ma'am. Would you please tell me again?
Okay, so the question is that before you start going for the counseling, you have to ask for a particular thing from the examiner. The thing that we have done in the case of MI when I was doing the history part. There was a very specific thing in history that I had mentioned that if you do not do this, you do not pass a case of MI. Not pulse. Pulse is something we ask everyone. Not a criteria for pass or fail. Thank you. It's called cardiovascular risk assessment. So this is the other case. So please make it a note today that this is the other case that you would need to ask your examiner that may I have the cardiovascular risk assessment chart. Now, sometimes they do have, sometimes they don't have. Now, if they have a chart for you, it's the similar chart if you all remember for your MCQ exam in Murtag that there was a big chart having different colors. It talks about systolic blood pressure, whether it's male or female. It talks about smoking, yes or no. It talks about cholesterol. So have you seen that table in Murtag where it had box, different colors, and in an MCQ scenario used to come where you had to plot like a graph and see what color the patient is on. Blue indicated 15 to 20%, for example, it's just an example. Green indicated 30 to 50. So do you all remember? If so, please tell me yes, otherwise I would need to talk a bit more detail on that.
Yes, ma'am.
You remember? Okay, good. Yes, a bit more yes for me to proceed because this is something important. Okay. So yes, I do see yes from many. So this is the time before you proceed, you have to ask from your examiner, may I have the cardiovascular risk assessment chart? Previously, when this case used to come, there was a chart, and just like MCQ, you would need to plot it and see which color box the patient is in. So it's taking a minute from you, because why? You need to see the systolic blood pressure, you need to see, you know already in history whether he's smoking or not, so you need to know all his details and plot it, which takes a bit of time. Should we do any interpretation in exam? So interpretation is if you're given the chart, if your examiner hands you over the chart, that's when you sit and interpret, which kills 1 minute. And then after interpreting, you say that yes, you are in this range of cardiovascular complications. Sometimes what happens more recently is that your examiner does not give you any chart. If it is, this is the best thing that you haven't got any chart. It saves a minute, you just go ahead. Okay? Okay. So moving on, but having said this again, if you get a chart, you have to sit and interpret and say what is the percentage risk for you to have cardiovascular complications depending upon the factors. In that case, I should ask for the chart. You should always ask for the chart in a case of, so this is a case of non-compliance to hypertension, you should always ask the cardiovascular risk assessment chart from the examiner. This is a must. If you do not ask, it's a big fail. Similarly, in this case, the non-compliance to hypertension, we ask for the chart. But in the case of MI, we ask questions in history to determine our cardiovascular risk assessment. So in a case of MI, we don't ask for the chart. We just say to the patient that now I'm going to ask you a few questions to determine your cardiovascular risk. So you know that as per the previous case, it is 3 S's: stress, smoking, sedentary lifestyle, diabetes, hypertension, hyperlipids, family history of cardiac deaths. That's right. So whether the chart is given or not, you ask. That is absolutely right. If you get it, it's your bad luck. If you don't get it, it's your good luck. Clear? Clear to everyone? Happy for me to proceed?
Yes, ma'am.
Okay. So moving on. Talking about, after my absolute cardiovascular risk assessment, I would move on with the what is hypertension. So I would like to again explain to you what is hypertension. Is increased blood pressure of your body. You would need to, so there can be many causes, some primary where there is no known cause, sometimes it can happen due to other causes. However, in your case, most likely it is a primary case of hypertension, and you would need to take your medication regularly. Why? Because if you do not take your medication regularly, in the long run, this increased blood pressure can affect a lot of organs in your body. So it can affect, starting off, it can affect your brain. There would be decreased blood supply of your brain leading to stroke. There would be decreased blood supply to your heart leading to any heart attacks. There can be decreased blood supply to your eye, causing damage to your eye, which we call hypertensive retinopathy. And it can also damage your kidneys, which we call hypertensive nephropathy. And it is for that reason we would like you to keep or take your medications regularly, so that we prevent you, or we can drag you from developing, so you'll get more time and you'll not develop these complications at an earlier stage. Now, I do know that I'm asking you to take your drug like very, very regularly. However, we also would like you to recommend or advise lifestyle modification. So if you know any case of diabetes, any case of obesity, any case of hypertension, it's always basically lifestyle. Once lifestyle doesn't help you, that's when you move on to medications. We already know that you have been diagnosed with hypertension and given medications. we still want you to have a good lifestyle. So whenever it comes to lifestyle modifications, the mnemonic that I use is A, B, C, D, E. So I'll write this one for all of you. So what we call is A. So what is A for? A is for alcohol. So please take alcohol to normal limits or to not more than 2 standard drinks. B is for blood pressure, and the other one is BMI. So please keep your blood pressure under control and try to do regular exercise. C is for smoking cigarettes. D is for diabetes plus diet. So we want you to keep your sugars in control if you have diabetes and to have a healthy balanced diet. And the last one is E, which is for exercise. So this is something you can memorize and say to any patient when you're talking about lifestyle, general lifestyle modifications, that please keep your alcohol to normal limits, have a good blood pressure, try to maintain your blood pressure, have a healthy diet, avoid smoking, and do some regular exercise. So these are the lifestyle. Along with that, I also want you to take your medication regularly to prevent complications or damage to your brain, eyes, heart, and to your kidneys. If it is difficult for you to if it is difficult for you to remember, you can please maintain a diary. A diary can always help you. You can write in there, or you can use some dosage boxes, or in Australia it's called the Webster pack, meaning they have small packs where you take all your medications together. It says Sunday, Monday, Tuesday, Wednesday. It comes in a pack where you get these medications in Sunday 8 o'clock, Sunday maybe the night 6 o'clock or something like that, and you keep taking according to what day and what time it is. That's called Webster or dosage boxes. Along with that, we would like you to have a lifestyle modification. Over here, always feel free. It's a counseling station. Give some reading materials, give some red flags, talk about review. That ends the case. Catching up again. So doing the full case again. So before I do that, let's show you all the slides. The causes of non-compliance are mainly 3: medication, patient, or physician problem. So first of all, talking about what is hypertension, talking about cardiovascular risk assessment, talking about A, B, C, D, E, alcohol, blood pressure, body weight, cigarettes, diabetes, diet, exercise, regular follow-up, refer to specialist, medications regularly. Good. So now let's do the full case again. So from the notes, I can see that you have been diagnosed with hypertension. Before you say there, so please talk about the general thing, that why have you come here? You have come here with a wound. Is your wound better now? How did you get this wound? Okay, but I could also see that you're coming with hypertension. Okay, before I move on, today I found your blood pressure is a bit to be elevated. I'd like to ask you a few questions. When were you diagnosed with hypertension? What symptoms did you have? What investigations were done? Who diagnosed hypertension for you? What medications were given? What was the drug? What was the dose? What was the frequency? Okay, moving on. After that, did you have regular follow-ups? Let's move on to the 3 categories. May I know why didn't you take your medication regularly? Was it a problem with the side effect, problem with the cost, problem with the frequency? Was it because that you were not aware of what is hypertension, or you have herbal beliefs? Was it a very short consultation between you and your doctor? Did he use a lot of medical terms? Was the complications of hypertension properly explained to you? Moving on to SADMA, past medical, surgical, and a family history. So before I start, I would like to know from the examiner, do I have any absolute cardiovascular risk assessment chart? If I have, I need to chart it. If I not, I go ahead. So what is hypertension? Increased blood pressure causing to all parts of your body. Now, if you don't treat this, or if you don't take the medications regularly, it can always be primary and secondary. Most likely, it seems in your case, it's primary. However, if you don't take this medication regularly, in the long term, it can affect your brain, your eyes, your heart, and your kidneys, which we call hypertensive retinopathy, hypertensive nephropathy. It can cause heart attack, it can cause you stroke. Now, what to do? You need to take your medications regularly. Apart from that, taking your medications regularly, you also need to have a very healthy lifestyle. alcohol to safe limits, body weight, have your blood pressures controlled, do not smoke, have a healthy balanced diet, do some regular exercise. If you have diabetes, keep that under control. And because you're forgetting, we can help you with some diary, some dosage boxes, and the 4 R's: refer, review, reading materials, and red flags. Clear? Not clear?
Clear, ma'am.
About red flags, should I explain or provide? Explaining meaning? So you just always tell about if anytime you're having blurring of vision, you're having headache, weakness in any part of your body, decreased urine output, please come back. Good? Okay. Any further questions?
Okay.
Yep, please ask. I did hear someone saying something. No questions. Everyone clear? Thank you. Thank you. So yes, I do see 2 to 3 clears. So who's doing the next case? Hopefully the last case for today. Anyone happy to do the last case? Yep, I'm happy to let you in, but prior to that, just making sure no one's in, because I did give you a chance. So let's see if anyone else is interested. If not, I would say I'm very happy to give you the second chance. Anyone for a role play? Yes, Dr. Rumana, please come up. Yep, I couldn't see anything from Dr. Tharinda yet. So yes, this is the first time it seems we get a typing message. Okay, not a problem. Yep, yes, Dr. Rumana, please come through.
Yes, ma'am.
Yep.
I just some of us beginners they feel shy to do role play.
That is something that is always going to be there. Okay, there's nothing to be shy. This one is a much easier platform than doing face to face, because no one's able to see you, what your facial expressions are going. Because when you do a live to live session, it becomes more difficult, further more difficult, because everyone keeps watching you, and that's how people get more anxious and more panicked and more nervous. So I would really say this is a nice platform which Dr. Ahmed's giving you all to start with. To be honest, yes, it is one of the best platforms because you only need to speak, no one's seeing you. So to everyone who's listening to me, please don't feel shy. There's nothing to be shy, and you're here to learn, and we are here to teach. If you're all prepared, you wouldn't be here, neither I would be teaching. Okay. So, Dr. Romana, are you happy to go with the next case with me?
Yeah.
Okay. So, starting your 2 minutes. If you're ready, give me a time, please. I'm just putting on my timer.
Yes, ma'am, I'm ready.
Okay. Ready? So your 2 minutes starts now. So this is a perform physical. I just want you to tell me. It's okay because I can't see you performing, but I want to know the points, please.
Okay.
Say it loud so that it sounds like you're performing. It's just you don't need to perform, you need to say. 2 minutes yours. Yep, your 2 minutes up.
Okay. Hello, doctor. How are you? This is Romana, junior doctor in this clinic.
So do you understand your task?
Yeah.
So here's the 28-year-old John. You can start.
Hello, John. How are you?
Yes, doctor, I'm pretty well. How are you?
Yeah, I am good. John, I came to know that your BP is elevated and further to reading is remain elevated.
Yeah, doctor. I mean, I really.
Yeah.
Yep. So I really don't know. You're telling me that my blood pressure is really, really high, though I don't feel anything. But yeah, it seems to be a bit high. I'm a bit concerned.
Yeah. So, do you know is there any BP elevated BP measurement previously?
My blood pressure, can't remember when was the last time I had my blood pressure checked, but it's like over the consecutive 2 visits, I'm having my blood pressure recorded because even on my previous visit, the doctor, you told me that my blood pressure is very high. So even this time as I'm back, you're telling me it's high. So,
So how many days you're having your BP rate?
Yeah, so the last time I saw you was about 2 days ago.
Okay. So before that you were okay, right?
Yeah, you didn't tell me anything anytime regarding my blood pressure, so I assumed that it was normal.
Okay. So do you have any other physical condition?
No.
Okay. So do you smoke?
Yes, I do.
Okay. So, do you take alcohol?
Yes.
So, do you take any recreational drug, or
No.
do you take any other medication for any disease?
No.
So, actually, I have to measure your weight.
Mm-hmm.
Okay. So,
So weigh about 65 kilos.
okay. So, I want to see your skin. Would you please allow me to examine your skin?
Sure.
Yeah, I want to examine your facial skin, your eyes, and
Yep, go ahead, doctor. So you're looking into my eyes. What are you looking for in my eyes?
I want to look for it's called xanthelasma.
Mm-hmm.
Is there any accumulation of which is called cholesterol? Okay, cholesterol is accumulated in the eyelid. It's called xanthelasma. So that I want to see your skin. Another one is your elevated blood pressure is maybe due to any other disease which may be manifested in skin. So that I want to see your skin.
Mm-hmm.
Okay. So I want to palpate your kidneys. Would you please allow me?
Yep. Yes, doctor. Certainly. But can you tell me what are you looking for in my kidneys? Like, yes, I did get in my eyes. You're looking for cholesterol deposits.
Okay. So I want to see whether any kidney abnormalities, like if any kind of chronic kidney disease. Chronic means a long time kidney disease you have, but you don't know, or any type of polycystic kidney disease. That means around the kidney there is a lot of cyst, bag of water, right? So it may causes raised blood pressure, because in that kidney can't excrete water from the body, then blood pressure become rises. Okay.
Then what will you get, doctor, as you are examining me? What will you get that will let you know that I have these problems?
If I get the kidney is palatable or kidney is palpable, then it may be due to kidney disease, like any other kidney disease I told you.
Oh, okay. And then how would you know that I have this chronic kidney problem that you were saying?
In that case, I will give you further test for the investigation.
Okay, but nothing on physical examination.
No, but it will guide me to go which way I can do investigation like this. So can I examine your chest?
Yeah.
Actually,
Would you like
to see is there any heart cause of hypertension?
Oh, okay, what can be the heart causes?
Actually, if there is like any kind of do you know heart? There is a large vessel comes from heart, like vein. So, is there any aortic disease? That means a large vessel disease. It may causes raised hypertension.
Oh, what do you call that?
Like it's the aortic disease or aortic coarctation like this.
So what will be your findings? What will you get if you examine me?
Okay, I'm examining. Okay, your heart is okay. There is nothing abnormalities.
Okay.
Okay. So can I see your blood pressure in the two hands? I want to compare blood pressure in both hands.
Sure, sure.
Okay.
So it's elevated on the other hand as well?
No, actually, okay, I have examined, but I see there is a delay in the pulsation in the two pulse, and there is a delay in the there is a difference in the BP between two arms.
How do you know that?
After measuring BP.
Yep, so I'm telling you the blood pressure is also elevated in the other arm. So almost similar.
Okay. So it's both on blood pressure is similar, right?
Yep.
Okay. So I want to see. Okay. So I want to see. Oh, okay. So blood pressure is similar in both arms, and pulse is slightly different, but it's okay. So I want to examine your abdomen. Okay. Okay. I want to examine your abdomen to exclude any type of hormonal disease, which is called like Cushing syndrome or Cohn syndrome. It's a kind of hormonal disease. Okay. So in case of Cushing syndrome, you may have high blood pressure.
Okay.
Okay. There is some stria in your abdomen. Okay. So SAM is, that means your skin is looking like yeah, due to accumulation of fat, your skin is become cracked.
Oh, so I have Cushing syndrome, doctor?
Yeah. There is a stretch mark in your abdomen. So we have to do some investigation. Yeah, you have supposed to having a disease which is called Cushing syndrome, but we want to do some investigation to make sure is it Cushing syndrome or not. So in that case, I want to do some hormonal test for you, like ACTH and some other test for Cushing syndrome. Yeah. So, do you want to ask me anything?
No, doctor. Everything sounds good.
Don't worry. After investigation, then we can confirm whether it's due to Cushing syndrome or any other condition.
Sure.
But I think it's due to Cushing syndrome.
Okay.
Okay. So please come and after due investigation result, and then we will consult again. Okay.
Sure.
Okay.
Thank you. So, Dr. Rumana, well tried. Okay, good effort put in. However, it's a case of physical examination where the biggest tip that I would give you, because yes, I know that you are starting, you are a beginner, but the biggest tip I would give you is that, like for example, what you had in your mind, I do not know, right? What is going in your mind, I do not know if you speak up. And the other thing is, you don't assume there is stria. Was there any place or anywhere that anyone had said you that there is a stria? There's no stria. Then regarding the pulse, how do you know there is a pulse problem, there is a blood pressure problem? You don't know until and unless you look, or I tell you that yes, there is a finding, isn't it? So you assume everything to be negative. So we don't assume everything to be positive. That no, there is stria, there is a gap in blood pressure, there is this thing. Okay, so we don't assume, we assume that everything is negative. If there is anything positive, your examiner is going to give you. Okay, so this is a case of coming to the case, but however, well tried. I'm happy that you participate, and I'm happy that you meet your time. Okay, yes, you may say wrong things, which is very much expected. So it's not that, like, you would all be saying the right things. So that's even, we don't expect you all, because you are at the stage of preparation. So it's very, very normal that you would make mistakes. But few things, like a very important tip if to give was this thing, because you are starting, so that you know how to improve yourself and you don't do it in the further. And the other thing is, well tried and good on time. Okay, so you have been speaking for 8 minutes, for which I really, really appreciate you. Coming back to the case, this is a case, it has only one task: perform physical. When it talks about perform physical, all you do is perform physical. It doesn't say about history, means we never take any history. So you go in and you say, hello John, this is Dr. Ibtisam, one of the doctors here. Today my task is to perform a physical examination, for which I'll be looking, feeling. If it gets painful or uncomfortable, please let me know, I'll stop. That's it. That's the first thing. And then you start with your patient. So the first thing that you say is, my task is to perform a physical examination for which I'll be looking, feeling. If it gets uncomfortable or painful, let me know and I'll stop. There's no rule that you have to say exactly the words I say. It's just that you take permission that I'm going to examine you, and I am aware that if it's uncomfortable for you, I will stop or I'll be more gentle. So there's no like correct formula that you have to say the same words, but it's just that you seek permission that I'm going to do this for you. Okay. If you know any physical examination, before you put your hands onto someone, always very, very important is that you need to wash your, you would need to wash your hands. So always we say, as you undress, or could you please expose the areas while I just wash my hands. So the first thing is you seek permission, you wash your hands, and you do a proper exposure. Good. Once you're done with that, let's move on. So this is a more of a theory part. What are the causes of, so this is a 30-year-old or a 28-year-old coming with high blood pressure. Whenever it's a young person coming with high blood pressure, as we know, it can be because of primary or secondary causes. Primary is usually familial or unknown cause, idiopathic causes, which is very normal if someone gets it at the age of 50 or 45, so it's like expected. However, if a 15-year-old boy, a 20-year-old boy develops hypertension, that's when we would be concerned to look for secondary causes. So over the side box, I would like everyone, because there are a lot of secondary boxes, please type in what are the secondary causes of hypertension. So Dr. Rumana did cover a few. She talked about coarctation of aorta, and she talked about polycystic kidney disease and Cushing's. Apart from these three, I would like, so I seek permission at first, not several times. No. So you seek permission right at the beginning. Hello, I'm Dr. Sam, one of the doctors here. My task is to perform a physical for which I'll be looking, feeling, and touching you. If it gets uncomfortable, please let me know. Can you please take off your shirts, wear shorts, expose yourself? I'll wash my hands and come. Very good. Renal artery stenosis, pheochromocytoma, thyrotoxicosis, glomerulonephritis, PVD. PVD, peripheral vascular disease. So peripheral vascular disease would come more with a Berger sign positive with maybe some bruise. And ABI high is what we get in PVD. So no PVD. Yes, acromegaly, hyperaldosteronism, or Conn syndrome, however you want to say it. Chronic kidney disease. Yes, chronic kidney disease can only be diagnosed on investigations. We do not have any physical finding by which we can say that this is chronic kidney disease, but yes, it's certainly differential. Drugs. Okay, drugs is again something you can get on history, that this patient is on certain drugs. Okay, so let's make a combo. So the combo is, let's start with endocrine. Okay, so on endocrine, number 1, acromegaly. What do you get in acromegaly? The features that on physical examination, if you examine a patient with acromegaly, you would get.
Enlarged jaw.
Yep, so that's called prognathism.
Yeah.
Sorry?
Enlargement of hand, prognathism.
Enlargement, so thick, big hands. Very good, big hands.
Acral enlargement, that means hands, feet.
Yep, acral enlargements, hands and feet, enlargement of hands, enlargement of feet, having a jaw prognathism, frontal bossing. Okay, so these are few of the features. Now moving on, so that's the first thing. Number 2, it can be because of hyperthyroidism. So what do you get in hyperthyroidism? You would get the anxious look. They're always anxious. On their hands, they'll have sweaty hands. They'll have irregular pulse.
Heat intolerance.
Sorry?
Heat intolerance, hot intolerance.
Yep, they'll have heat intolerance, but that's something they will complain, right? So you can't see anything on physical examination apart from sweating. Apart from that,
proptosis.
Proptosis, yes, they may have proptosis, lid lag, lid retraction. They may have, importantly, a thyroid gland enlarged with a thyroid bruit itself.
Tremor.
Yes, very good. They can have tremors. Let's move on. So we did a lot for hyperthyroidism. Let's move on. Cushing's. What will Cushing's have?
Moon phases, buffalo hump, truncal obesity, central obesity, and stria.
Very good. So they'll have moon phase, buffalo hump, central obesity, stria. Very good. Last one is pheochromocytoma. What will pheochromocytoma have?
Hypertension.
So yes, so hypertension. You're already seeing that this patient's coming with hypertension. What else?
Palpitation.
So palpitation is something, if I tell you, doctor, I have palpitations, can you examine and prove it that I have palpitations?
Hyperpigmentation in skin.
Hyperpigmentation would be more for hemochromatosis or so I would say hemochromatosis would have more hyperpigmentation. Okay, pheochromocytoma, if you all remember, they come with headache, they come with palpitation, and so this is a headache or palpitation we can't elicit on physical. The thing we can elicit on physical is they usually come with flushing. So their face would be flushing. Okay, that's the only thing maybe we can see in a case of pheochromocytoma. So we are done with 4 endocrine causes. Moving on to renal causes. So renal causes, number 1 is polycystic kidney disease. So polycystic kidney disease, what will you get? Palatable kidneys, right? Moving on, the other one is glomerulonephritis. A case of glomerulonephritis, what will you get? You will get, as you do an office test, you'll get urine dipstick, high for bloods, for protein. Good. And the last one is renal artery stenosis. What do you get in renal artery stenosis?
Bruit.
You get a renal bruit. So let's start the case now. I'm going to patch up the case. So when you are going to do a physical examination, starting off washing off my hands, proper exposure, I'm going to examine you. So I'm looking into the general appearance of the patient. The patient does not have any anxious look. Anxious meaning hyperthyroidism. The patient does not have any flushing of face, meaning ruling out pheochromocytoma. I cannot see any frontal bossing jaw prognathism, meaning I'm ruling out acromegaly. Let's come to the hands. On the hands, I cannot appreciate any thick big hands, meaning acromegaly. No sweating, no tremor. Let's come, so from the hands, let's go more up. I'm measuring the pulse. The rate, rhythm seems to be normal. So no atrial fibrillation, meaning no hyperthyroidism. So the radial symmetry, and there is no radiofemoral delay. Why radiofemoral delay? Because that's the last cause, coarctation of aorta will have a radiofemoral delay. So place one hand on the pulse, place one hand on the femoral and say there is no radiofemoral delay. Next, I would like to measure the blood pressure in all the 4 limbs, both sitting and standing. Why? We want to rule out postural hypotension. Then, let's move on to the eyes. On the eyes, in general, you're looking for anemia. Okay, xanthelasma, good. But importantly, anyone coming with hypertension, we always have to look. Fundoscopy of the eye for hypertensive retinopathy changes. Anyone coming with hypertension, you don't do a fundoscopy. It's a very big error. Then coming on to the neck, I'm palpating the thyroid gland, and if it is enlarged, I'll hear for a thyroid bruit. Next, moving on, I'm coming to the first to the heart. On the heart, both my heart sounds are dual. There are no added sounds, so I just auscultate. I don't do inspection, palpation. I just say On auscultation, on all the 4 areas, my heart sounds are dual with no added sounds. On my respiratory, just at the back, I'll hear for creps, so equal air entry with no crepitations. Moving on to the abdomen. Abdomen is something I will start with inspection, palpation, percussion, auscultation. On inspection, no distension or scar marks. On palpation, I'm focusing particularly on palatable kidneys. Why? To rule out polycystic. Percussion, okay, tympanitic. On auscultation, I'm focusing on, yes, bowel sounds are heard, but importantly, renal bruit. Renal bruit. So there's no renal bruit indicating no renal artery stenosis. Then I would like to finish off my examination by doing office tests. So please always remember, abdomen auscultation is never the end. We always have to finish quickly by saying DRE genitalia and DRE genitalia and hernia intact. Let's finish off by office test, a urine dipstick. In urine dipstick, I'm particularly looking for bloods and protein. Why? I would like to rule out glomerulonephritis. So again, making it the complete way how I would say it, because in the exam I'm not going to say I'm excluding this one, I'm excluding this one. So in the exam, the way I would do is, hello, this is Dr. Ibtisam, one of the doctors here. Today my task is to perform a physical examination on you, for which I'll be looking and feeling. If it gets uncomfortable, please let me know and I'll stop. So could you please expose yourself while I wash my hands? On general appearance, there is no signs of anxiousness, there is no flushing, or there is no moon face. I cannot see any frontal bossing or any jaw prognatism. Coming on to the hands, no thick big hands, no sweaty hands, no tremors. On the pulse, I'm looking at the pulse, the rate is approximately 80. However, the rhythm is regularly regular, the radio-radial symmetry with no radiofemoral delay. I'd like to measure the blood pressure in all the 4 limbs, both sitting and standing. Coming on to the face. On the face, from the eyes, I'm looking for any, yes, anemia, jaundice, xanthelasma, but importantly, I'm doing a fundoscopy. Moving on to the neck, I'm palpating the thyroid gland from the back. If it is enlarged, I'll hear for a thyroid bruit. Coming on to my heart, on auscultation on all the 4 areas, my heart sounds are dual with no added sounds. On the chest, just at the base of my lungs at the back, listening that the air entry is bilaterally equal and there is no added sounds or no creps. Coming to the abdomen on inspection, I cannot see any central obesity. I cannot see any stria, no distension, no scar marks. On palpation, no tenderness. I'm particularly focusing on, so I'll not go for liver and spleen. Why? Because I'm particularly focusing on my palatable kidneys. Kidneys are not palatable. Percussion, okay, normal. Auscultation, apart from my bowel sounds, I want to hear particularly for renal bruit. Coming on to the assuming genitalia hernia and my digital rectal is normal, I'd like to finish off with office tests, which is a urine dipstick and a blood sugar. My urine dipstick, I would like to focus on proteins and bloods. Why? Because I want to rule out there is no acute glomerulonephritis. I would wash my hands again and say my patient, thanks. Clear? Not clear. I'm sorry that this is apart from saying what I have said. So in the exam, you keep doing and you keep saying. So your mouth and your hand both works. So you just don't keep quiet and you just don't keep listening. At the same time, you don't only keep saying without touching your patient. So in a case of perform physical examination, you keep touching and you keep saying. So both goes simultaneously, which is a lot more difficult.
Ma'am, where do we measure the BP in the lower limbs?
Okay, so usually you won't have to measure blood pressure in lower limbs. You only measure one limb, which you have to ideally measure in the exam as well. And then after that, you say that I will measure all other limbs sitting and standing. Okay, so because if you start measuring 4 limbs blood pressure, it takes your 8 minutes. You can't do anything further. Okay, so you don't even measure both limbs. You just measure one and you say to the examiner that my blood pressure, that's what I have got, and I'll measure it at the rest. Okay, so there is no situation where you ever have to measure the blood pressure of the lower limbs.
Okay.
That ends our cases for today. So please let me know if you all are clear and if any questions. So the last 10 minutes for questions. I tried going a bit fast. Were you all able to catch up with me? Because you can understand that I have started going a bit fast because we did 4 cases today. So we have just jumped one more from 3 to 4, which is a good sign. Were you all able to catch with me? Should I ask drug history? No, dear. Physical examination, no asking. Thank you. Any questions regarding any of the 4 cases that we have done so far? Or anything from the previous cases as well, I don't mind. Next class, don't know, dear. Need to talk to Dr. Ahmed. A bit busy for the next 2 weeks, but let's see what happens. Sure, I can, but sometimes I really get very, very late. So please don't mind me. Sometimes not. Do we need to measure JVP? Ideally, no. But I would try whenever I get time. I would certainly try, but please do not feel bad if anytime I'm not able to reply. So feel free to ask me in the group whenever I'm in. So please feel free to ask me here. Sorry, dear, it's just because I like very, very busy. So I do miss things a lot of times. Yep. Any questions? So I think if anyone, you're welcome to ask me, but if you don't get a reply, please feel free to ask me whenever you get me on site. And don't worry, I'll try answering if I can. I certainly will. If I can't, I'll try looking up for you and then letting you know. Okay? So don't worry about asking anything. Fundoscopy, yes, it's a critical error. Just like medications, allergies, bleeding, blood group, hypertension, fundoscopy, it's just like that. What another, dear? So critical error for this case is fundoscopy. But then again, if you don't rule out 5 of your causes amongst so many and then you do a fundoscopy, that's even a fail. But if you don't do fundoscopy, it's a critical error. No, any other, I would say that's what I'm saying. So any other would become a more of a collective thing that amongst so many of endocrine, so many of renal causes, you missed out 3 to 4 important ones. That becomes a fail. If you're not able to perform well, your hands are shaking, you're doing the wrong things, that's a fail. You're doing one thing, you're saying another thing, that's a fail. You're only saying you're not doing, that's a fail. Okay? You did everything perfect, you didn't do a fundoscopy, that's a fail. Good. So we are near to ending. Any more questions before I do see? I think I have Dr. Ahmed on site, it seems. So any other questions before I hand it over to him?
Oh, hi everyone. Okay, I just came. Okay, so probably it's a fantastic class. Actually, I went off somewhere. Giving that one, just came back. Okay, so thank you, Dr. Prasham, and I'll talk to you about your availability, and also I'll let them know, like
Sure.
yeah, when you'll be available. Yeah, it's always welcome, and would be lucky to have you again. Okay, so so everyone, if there are questions, normally we appreciate more at the end of the class, as she was asking. Also, you can keep some questions in the same group. Either me or she, any one of them can answer at her convenient time. You can understand actually the workload we have actually, but we'll try. Like it's like not everything we can answer, but whenever it comes to our notification, we'll try that. It's like that. So you can keep these things here, like maybe also she need rest now, so you can keep some questions. We can see any one of them later. That's not a problem. And so that's the thing. And I think and tomorrow, I think I told you, like, as like extra class, I just feel those of are my MCQ students, I feel maybe a little more better with the ECG, but here not everyone is my MCQ student, so I feel like some of you need separate class on ECG. So I was planning to take an extra class on ECG. So tomorrow we'll premiere that one in the groups. So you're going to see that, and the file is already uploaded. So just check the file, like out of the available ECGs that are available. So you can just read that one prior and just see the class later. Okay, like tomorrow, the time is the same time, like So catch me tomorrow in the time with the ECG class. Okay, I hope so. Some of the confusion related to ECG, because I saw some people couldn't understand the leads, like this should not happen, and you have to be very fast there, and it's a pressure situation, and if you have some issue with ECG, you might lose the whole case if you misinterpret the ECG, like whole case might be. Yeah, so if you give a wrong statement with the ECG, like in your whole case is going counted as a critical error. Okay, hope so things would be clear after that. And thank you, Dr. Itasham, again for with us. Yeah, you're part of the thing now. Thank you so much again. Yeah, thank you again. Okay, thank you everyone. Okay, so have a nice day, everyone. Okay, bye bye.
Yeah. Thank you. Bye bye.
Bye bye.